Hello everyone, my name is Lydia Hammond. I, along with Elisa, Yvonne Caballero, Laura Clark, Ciani Palencia, and Yanxiang, will be discussing improving access to healthcare, telehealth. Some background information: in 1924, telehealth was actually foreshadowed in a radio news magazine in which it depicted a doctor coming through the radio to view or assess their patients. In 1960s and 70s, there was a program entitled The Space Technology Applied to Rural Papago Advanced Healthcare. It was funded by the Department of Health and Human Services, as well as the National Aeronautics and Space Administration. It provided health care to isolated Indian reservations, as well as the astronauts. According to CMS, in 2015, healthcare spending grew 5.8%. It resulted in $3.2 trillion, or $9,990 spent per person. Some triggers of our topic: obviously the cost of healthcare, as our expenditure is growing with every year, as well as the movement from inner city to provinces. Cities such as Valencia, Bakersfield, and Visalia, as evidenced in Northern California, are up-and-coming communities, but many have not established their hospital facilities as of yet. So the community members have to seek healthcare outside of their county. In terms of patient-centered care, we all know it is currently a hot topic of discussion, and through telehealth, we can attain healthcare maintenance with more frequent visits, as well as being open for communication and consultations with our patients. It can benefit with lifestyle and behavior modifications, such as diet management or diabetes management. It allows us to have a broader reach. Many of our elderly patients find it difficult to find transportation to facilities, which often is the reason why they don't keep their follow-up appointments. By having telehealth, many can go to their more local facility to be able to speak with their doctor. As for the uprising of technology, we can see, such as the one here in this presentation, all of our peers do not have to actually be in the same room to get this done, so why not use this for the well-being of our health? Our clinical question, stated in PICO format, asks: do residents of rural areas experience decreased hospitalizations when utilizing telehealth compared to those who seek direct medical care? Our stakeholders who have been identified include physicians who can become more available to their patients, again referencing the follow-up care; insurance companies who can avoid the cost of urgent care visits or emergency room visits; hospitals can benefit because a tele patient does not actually take up a bed, leaving that facility more open to local community members who do actually need to see an emergency room. This is also helpful for patients who are unsure as whether they should see their outpatient physician or if they do need to go to the ER. The general public can benefit because they're able to once again speak with their physician more frequently, and the government can also benefit by decreasing the GDP in the healthcare expenditures.
Okay, my name is Ciani Palencia, and I will be introducing some of the research that we discovered for our project. Ms. Tian discovered a study about a project called TREAT, which stands for Telemedicine for Research, Education, Access, and Treatment. And this project looked at how teleconferencing helped diabetics in rural Pennsylvania with a hemoglobin greater than 7.0% control their blood sugars. And what they found is that they had a comparable outcome similar to that to the traditional face-to-face patient and provider meeting. And Miss Laura is going to talk about the Arizona experience.
Hello, my name is Laura Clark, and the research that I contributed to our systemic search was an article about the Arizona experience. This was a study that looked at the effects of the Arizona telemedicine program on rural communities. This study was, this program was founded by the state government in 1986, and it was designed to meet the needs of underserved and rural communities throughout the state. The study found that this program had a high level of patient satisfaction, and patients reported that they felt that their care was more accessible, that it was more cost effective, and they're more likely to get specialized treatment. Overall, the telemedicine care that was delivered was high quality, cost effective, and timely.
And my study that I found for this project is a project called ECHO, which stands for Extension for Community Healthcare Outcomes. It was created in New Mexico by Dr. Aurora, originally to help patients with hepatitis. So the purpose of ECHO is to create knowledge networks and moving knowledge instead of patients to help them with their care. So people in rural communities in New Mexico have no access to specialty care, and rather having them travel extensively for long or wait long periods for clinical appointments, they would use ECHO, the network, through teleconferencing or video conferencing to have access to this care. So the specialists would move their knowledge to the people in their rural communities to their medical home, usually with their primary care provider. So they share their specialty knowledge with a primary care provider, and they don't have to travel. So this model has actually been, the outcomes of this model is, again, similar to TREAT, in which the outcomes for the patients is similar to the traditional face-to-face patient and provider care. And because of that, they plan on extending this project to other settings like the VA and other states too. And Ms. Yang Tian has also found a shared decision-making in glycemic management study, which she will also be talking about in the appendices section. Well, this is the section that I will be talking about extensively, and it's the grading the evidence section. And so the model of EBP that we chose is the Iowa model that we learned about in class. The purpose of evidence-based practice is so the synthesis of evidence, its implementation, and to evaluate how the evidence impacts patient care, and if the setting or environment considerations will affect the evidence and its implementation. So as Lydia mentioned earlier, we begin with problem-focused triggers, such as quality improvement, risk surveillance, benchmarking data, financial data, recurrent clinical problems. This model is widely disseminated and adopted between academic and clinical circles. So the strength of this model is pretty relevant. So our PICO question was to research the use of telehealth as a possible solution to reaching rural communities. And Healthy People 2020's one of their goals is access to healthcare. So this is in line with that problem trigger. Okay, this is the schematic for the Iowa model. We're here under problem-focused triggers, and then is the topic a priority for the organization? And we answer yes. Many organizations do view access to healthcare as a problem, so they have formed teams and they have conducted research. We are at the critique and synthesize research phase. And is there a sufficient research base? And the answer is yes. So we do everything in this box here where it's under pilot the change in practice. And then we move on to, is the change appropriate for the adoption in practice? So now we're moving towards guidelines and recommendations. And we'll learn more about that later. So grading the evidence, we use EBP rating systems. And throughout, there are many rating systems, but they primarily go over the quality of the research, of the individual research, and the strength of the body of evidence, the strength of what they found. So they hit these primary domains and elements: quality, quantity, consistency, and relevance, as you see here. And most of the research will fall into one of these 4 categories. So obviously, systematic reviews and randomized clinical trials are the highest level 1 type research. That is ideal. Most of the research that we discovered is observational studies. We had a study question and comparability of subjects using cohorts. So we compared 2 groups. We gave them an intervention, and we did statistical analysis and looked at the outcome. And we did the rest in there. So the model that we chose to grade our evidence is the grade working group. And it rates the strength of evidence in 2 ways. One is the quality of the evidence, and it's either high, moderate, low, or very low. And just because it says low doesn't mean that the research is not valid or the recommendations are not important or capable of being used. It just means that you would need to do more research to strengthen the findings. So here's an example of 3 of our topics. And as you see, the article that I found was as low, and further research is required, primarily because it is not a randomized study. There was exclusion and inclusion criteria, and there was exclusion criteria for a majority of our research articles. So this is the other criteria, the strength of the recommendations. So it's either strong or they're weak. And these are a couple of examples of the same example articles that I picked. So the strong points is the use of statistical analysis. And in an example of the ECHO study, since it was not randomized, they compensated using a multivariate analysis so that the treatment between the 2 groups did not differ too much. And if you notice in the shared decision-making study, the sample size is too small, so they'd have to do an altered statistical analysis to generalize the findings. And then in the treat model, we had an adequate sample size, and it was quasi-experimental. So again, we need statistical analysis, and throughout all these studies, it is relevant and it's consistent since it's based on previous research. And Laura will talk about the synthesis of research.
Hello, my name is Laura. I had the section Synthesis of Research. Our evidence-based practice review grid listed the purpose and research question, the research design, sample, independent variables and measures, statistical tests, results, implications, general strengths and weaknesses, quality of overall study, and we rated this by stating whether the evidence was good, fair, or poor, and then a summary of statement for practice. Some of the common themes that we found throughout our research was increased access to specialized care to rural and underserved communities. Telemedicine was able to detect changes in patients' conditions. Therefore, the physicians were able to change their plan of care and reduce the possibility of hospitalization and then readmission within 30 to 90 days of discharge. Telemedicine was also shown to be very cost-effective. There was a high patient satisfaction when using telemedicine. Patients felt that they were more in control of their health, better able to manage their chronic diseases, such as diabetes or heart failure. These are some of the conditions we looked at in terms of telemedicine. Thank you.
Hello everyone, my name is Elisa, and here are our recommendations. Telehealth should be introduced into rural areas. This allows people to receive care within their local area without having to travel to metropolitan centers. It also reduces travel costs. and reduces physical and practice inconvenience. All members of the healthcare team to utilize telehealth technology should have adequate training and continued technical support. We should also establish a vision to explain to the community how telemedicine will contribute to achieving goals and objectives. Telemedicine should be convenient and accessible, and it should be available where needed. Mainstream telemedicine into the standard care process, which will make it more accepted by the community where this is being implemented, and identify leaders and champions to help implement, coordinate, and provide support to all users.
Hi, my name is Yvonne, and I will be discussing about the proposed guidelines for our evidence-based practice regarding the use of telehealth or improvement of healthcare access to the use of telehealth for veterans, underserved populations, and rural communities. And from what we had found out is that there are improvements with the use of telehealth for veterans, and according to one literature about veterans and the use of telehealth is that there was a study with advanced comprehensive diabetes care that was conducted. They conducted a pilot study, and it showed that telehealth have shown an improvement in a span of 6 months, as evidenced by a drop from a 10.5 to 9.2 compared to the regular population sample that showed basically a drop from 10.5 to 10.2. So that's a significant change from 10.5 to 9.2 compared to 10.5 to 10.2. And it showed an improved blood sugar, lower blood pressure, and better self-care, diabetes self-care. So with telehealth in regards to veterans, it has shown to help with their healthcare access. So our proposed guidelines is that individual hospitals should be educated about telehealth and its advantages. More telehealth resources should be created for access for patients upon discharge and for continued teaching as a resource guide, as well as establishing standardized teaching for uncomplicated diagnosis through the use of telehealth, of course, and it should be readily available for patients with newly diagnosed chronic illnesses. As for the underserved populations, it has shown to also improve access to healthcare, as evidenced by a study done by Sloan, Source, and Sprang. The results indicated that the use of telehealth through video conferencing with parents and children with special needs have shown improved child behavior and decreased parent distress. So we have recommended that telehealth can be instituted in schools as well as for educators as a reference guide, also for healthcare practitioners to communicate with those individuals. Telehealth can be minimally cost-effective with low equipment needed, such as microphones and computer access. And lastly, in the rural communities, telehealth have shown significant improvement in healthcare access. And this was evidenced by the fact that it lowers healthcare cost, although healthcare quality through telehealth is still questionable. According to a study by Mofat and Ellie, the advantage of the use of telehealth in rural communities may lie in the continued education and professional development of healthcare professionals, which indirectly benefits rural patients through the upskilling of rural health professionals via professional development and experiential learning received from telehealth. Therefore, we recommend that professionals should be educated about telehealth and incorporation of telehealth through the current curriculums. Literature about the use of telehealth have indicated that it has decreased healthcare costs and also indirectly improved healthcare professional skills in the rural setting. And telehealth should be implemented to keep practitioners and healthcare practitioners upskilled in their profession. Our evaluation plan is, as discussed before, is education about telehealth, incorporation of telehealth to current nursing curriculums, introduction of telehealth to hospitals, and incorporation of it for hospitals as well. Guidelines of the use of telehealth and implementation of telehealth should be created. Therefore, it has standardized telehealth education for patients with chronic illnesses, which can be very beneficial, and incorporation of telehealth with discharge instructions for patients whenever available. There are some hospitals that are now using telehealth as well as part of their discharge instructions and making telehealth as a requirement. The data about telehealth about the proposed guidelines were based on current literatures and studies, specifically with the use of telehealth with veterans, underserved populations, and rural communities. And research have shown that telehealth have improved healthcare access for these specific population group, which is specifically the veterans, the rural communities, and underserved populations. And quality of healthcare is still yet to be determined, but the lack of current research on the topic needs to be further researched. Current literature about telehealth are substantive and credible, and all the reviewed research have all indicated that telehealth have improved healthcare access with these specific population.
Hello, my name is Yanxiang. I'm going to talk about appendices. Our appendices include evidence-based practice literature review grid, data collection form for hemoglobin A1C, and questionnaire for diabetes self-management. You have already seen our EBP literature review grid in the presentation of synthesis of research on slide 17 and 18. We're using the practice of telemedicine on glycemic control as an example. In our data collection form, we have the baseline hemoglobin A1C, which will be tested before our change of practice. We also have 3 follow-ups at 3 months, 6 months, and 9 months after our change of practice. The data will be collected from electronic records. Our questionnaire for diabetes self-management includes the following questions. Do you check your blood sugar at home? Do you inject insulin at home? If yes, do you have any difficulties in injecting yourself insulin? Do you have any difficulties in getting supplies such as glucose meter, lancets, or syringes? Do you take your diabetic medication on time? If not, why? What food do you eat for breakfast, lunch, and dinner in a typical day? Do you do regular physical exercise? If yes, what exercise do you do? How many hours in a week do you exercise? Do you think it is very hard for you to take care of your diabetes at home? This is the end of presentation of appendices. Thank you very much for watching.